Thank you for that nice, oops, hold on. Thank you for that nice introduction, Simone. You're a natural. So I'm sharing my screen. If there's, can everyone see that? If there's a problem, please raise your hand or say something in the chat. So I'm going to, this is a two-way street. I got your comments, and if there are questions and comments, I definitely want to, the whole point of this is to kind of talk with people and answer questions. But I do have a few slides I want to go through, and maybe these may be kind of basic, but maybe it's a little bit like making you eat your vegetables while I answer your questions too. So these are some of the things that I like to say to people, but it's really hard to say when you're a psychiatrist and you're working with people and you have 20 minutes or half an hour, or, to meet them with and have a discussion. You can't always do all the teaching you want or education that you want to do. And I've also learned that, even I work a lot with medical students and psychiatric residents, and nowadays we don't have a lot of face-to-face time. A lot of it is doing like pointing people to resources, and it turns out adults probably learn better at their own pace without me giving a long lecture. So I'll try to keep that in mind. I don't have any commercial relationships with any pharmaceutical or other for-profit companies. You may notice that you probably all know already that all drugs have like two names. They have this generic name and the brand name. So working with medical students and residents, we've been trained to just use the generic names, but I may flip into the brand names because they're probably better known to you. But so I'll flip back and forth. I'll try my best, but feel free to ask in the chat like what the questions is, or if you're on, it sounds like everyone's on their computer, you can just Google the name, the brand, the names also. So one of the things that I always I wish I had time to teach everyone is just about psychopharmacology, just some of the basics. And so I'm going to spend maybe 10 or 15 minutes talking about the basics, and all the details you have to learn yourself, but hopefully this is like teaching you the framework about which you can think about psychiatric medications. Okay, so there's and I like to think of it as there's actually 4 basic food groups of medications: the mood stabilizers, the antidepressants, atypical antipsychotics, and sedative hypnotics. And this is the way psychiatrists think about meds. Like we put the meds, that way we don't have to learn each medication individually on its own, but we group them into clusters, and then you can learn about kind of general principles about each cluster. Now, of course, each medication within the cluster has some of its own unique characteristics, but this is the way to kind of think about medications. And I hope you will all, if you're taking medications, to try to at least understand like which group that the medication you're in is within, and you can talk to your doctors about this, find out which group it's in and why you're taking it. I think that will help you feel better about your medications and help you understand and give you a rationale going forward about how to take medications and how or at a minimum how psychiatrists think about this. So let me just, and so by the way, so I make it simple. We have these 4 food groups, but it turns out that, for many people, they're on more than one medication. And so this is a study looking at the number of patients and what percentage of them were on, how many meds was each one on. So you can see combination therapy out of 258 patients with bipolar disorder, combination therapy, meaning taking more than one, was the rule, not the exception. So you can see here that 20% of the people were on 3 medications, 18% were on 4, 12% were on 5, and others. So the average is like 4 medications. So it can be really confusing to be on these meds. And I think, just to be realistic, everyone is taking, not everyone, but all these people are taking more than one medication. Okay, so I'm going to go through these, not so much the antidepressants, but I'll go through these other 3 groups pretty quickly, and we'll talk about them, okay? So mood stabilizers are, the basic ones really are lithium and Depa Code, and then sometimes Tegretol. And these are taken every day. And there's a little link here on Wikipedia if you want to look at it. If you look on Wikipedia, mood stabilizer, it gives you a definition. But these are really the only 3. So when they talk about like bipolar disorder, the main treatment is mood stabilizers. It's one of these 3. So people really think about trying one of these 3. This is just a couple of fun slides on lithium. This is John Cade, the psychiatrist who kind of discovered lithium. This is Royal Park Hospital in Australia, where he first learned where he first used it. It's the best study that has the highest efficacy. It has two other really interesting features that we know from like lab tests on neurons, that it actually seems to protect neurons from stressors. And actually people who take lithium, for whatever reason, have lower suicide rates. We don't know why. You would think that maybe you would have higher, because if you took a lot of it, you could die, right? So you would think maybe people who were prescribed it could have a higher rate of suicide, but no, they have a lower rate. This is just this funny studies on lithium that are like kind of probably beyond me, like how they determine like lithium is neuroprotective. But if you give, these are supposed to be a picture of a neuron. If you give neurons lithium, you can see that this neuron compared to this one has these more little branches. That means it's like making more connections to its neighbors. So that's supposed to be healthy. And so if the person has more gray matter in the brain, gray matter is what represents the neuronal bodies, you can see that lithium is good for it. And these are studies in like test tubes, but they also have test studies in people where they can take MRIs and compare, lithium. And then you could just take people who take lithium after a while, their gray matter volume, which is the neurons part. The white matter of the brain is just the axons. The gray matter is the nuclei of the neurons. That goes up if you take lithium for a while. So it's kind of just interesting. Now there's all these studies looking at lithium decreasing suicide rates, and like lithium is a little bit under kind of a short commodity these days because of batteries. All those lithium batteries need lithium too. But it's not, it's still relatively inexpensive, and it's very natural. I mean, if people want to think about what's a natural substance, lithium is very natural. I think they dig it up out of the ground. This is like in Peru, I believe. They have big mines there of lithium. They've done these really funny, so not only in individuals, but they've done these like epidemiological studies, like geographic regions, like zip codes in the United States that have a natural higher lithium level in the water, and just in the drinking water, have lower suicide rates. So it's just kind of interesting. So if you put lithium in people's water, even tiny amounts, it seems to have some beneficial effect. They also have lower homicide rates, by the way, as well. So we don't know. And then this is just people on lithium. They have this decreased suicide rates and attempts during long-term lithium treatment. No other medication in psychiatry has this. And they've looked, believe you me, they've looked, but this is what they haven't found it with other we believe it's true for antidepressants, but we haven't been able to prove it as markedly as with lithium. And here's this, so there's a six-fold lower risk when people are on lithium. And then here's this kind of funny commentary by a person with bipolar disorder who wrote a book actually herself. I forgot the name of the book now. I'll remember it in a moment, I'm sure. But she wrote this kind of funny little essay called "I Don't Believe in God, but I Believe in Lithium." It's a little bit of a stressful story because she's starting to have kidney problems with the lithium, and so has to now think about going off the lithium because of her kidney problems. And she's been stable for a while, it sounds like, in the story. So the lithium has these like short-term side effects that are annoying, but will either go away, or if you stop the medication, won't be a problem. But it does have two other side effects that are kind of more problematic. One is the kidney side effects, which we also known as renal side effects, and the other one is thyroid. So I would say that I wrote this wrong here. So it should be once a day dosing is optimal. So it turns out that they've done these studies that if you take lithium once a day as opposed to 2 or 3 times a day, it's probably better for your kidneys. Your kidney doesn't mind, moderately high. It doesn't want a toxic level of lithium, obviously, but it doesn't mind a moderate level of lithium each day, so long as it gets a little break. So if every day you just take it once, you kind of have a peak right after you take it, and then the rest of the day it kind of gets lower and lower. And it needs that. It's good for the kidneys to have that little lower level period. They actually have tried, like, if once a day is good, maybe every other day would be even better for your kidneys. Unfortunately, when they tried that study, a lot of people relapse. So every other day, for whatever reason, doesn't work that well. Amiloride is a medication that we don't know if it helps protect your kidneys or not, but it does help with people who have to pee a lot. So lithium is a salt. If you take it, it makes you pee a lot. If you take low doses of amiloride, that can help with that. We think it may be protective of your kidneys, but we're not really sure. So I can't recommend it based on like it's going to help, but at least you won't have to wake up so many times at night to pee. That's the answer for that. Thyroid is associated with increased risk of hypothyroidism. So thyroid will also suppress, lithium will also suppress your thyroid. Now, I will say, and I thought I had a slide on this, but most doctors would much prefer to treat hypothyroidism than lithium, because hypothyroidism is easy to treat. We have the hormone that is made by the thyroid, and we can just give it to you. So even though the lithium will suppress your own thyroid, your thyroid hormone can be replaced pretty easily. Lithium comes in several different formulations. Lithium carbonate is the original and the cheapest, and it's considered immediate release. Lithium citrate is this liquid. Apparently it's on this shortage now, which is kind of a pain, because if you come into 300 milligram capsules, let's say you want to take 175 milligrams, it's really hard with the 300 milligram capsule. If you take lithium citrate, it's a liquid, you can kind of judge for yourself how much you want to take. Lithobid is this lithium carbonate is packed tightly in wax and other components to make it dissolve more slowly. So when you take it, it releases into your body more slowly. Escalith is the brand name. There's Escalith CR, which is continuous release, a slow release version of lithium carbonate. And so when all these other medications that are called SR or CR, those are a sustained release or extended release and stuff like that, XR. Basically, they're just pills that are packed in some kind of a polymer or wax that dissolves more slowly. There's a question about lithium. Isn't lithium an archaic or old school medication? Aren't there more modern psychiatric drugs with less severe side effects? It depends on the person. I would say you will get about 20 to 25% of people with bipolar disorder can take lithium, and that's all they ever need. That's some studies show like there are people who they just take lithium and then that's it. They don't need anything else. So it's definitely worth trying lithium. So someone has asked a question about people who take lithium can't have chemotherapy in case of cancer. I don't think so. It should be fine. I would just talk with your doctor about it. I think if you have kidney cancer or something like that, then maybe you have to be, you probably need to be more careful. But or while you're getting the chemo infusion, you probably might skip a dose of lithium itself. But I don't think you need to make, you don't need to get off lithium. That's my understanding, at least. I would work with the oncologist as a psychiatrist and see what's the deal. So just to summarize.
A couple other questions before we move on. I guess this is related to your earlier side, but folks wanted to know what you thought of various gene tests in relation to prescribing for bipolar disorder.
Oh, that I'm going to have to punt on. I've done a lot. There's a fair bit of study and research on that. I don't think it's worth the money. I'll give you the short answer. The various gene tests in relation to prescribing any psychiatric medication, they're probably not worth the money at this point. That's a short answer. I don't order the tests. I think there might be some really specific or unusual situations where you could order that test and it might be helpful. But I generally think that there have been some studies looking at how helpful are they to doctors, and they haven't been shown to be helpful to patients.
Just one more. Is there a group labeled antipsychotics or only atypical antipsychotics?
Oh, I'll get to that one when we get there.
All right, great.
Yeah. So lithium summary is just the best study with the highest efficacy. It or offers neuroprotection, decreases suicide rates, but it does have this side effect of thyroid and kidney problems, particularly kidney. I think kidney is more problematic than the thyroid. And remember, it's a salt, so think of it as like this salt that you would take. And the fountains of Lithia. I don't know if you guys know about that, but like in France, people used to bathe in these fountains and stuff. Anyways, and had high levels of lithium. Drink the waters. It generally works best as a preventative agent. So lithium, once you're really ill, it's not so great. But it's for some reason it seems to decrease the amount of cycling that people make. So once you're feeling okay, it's good to get on lithium because it will prevent more episodes from happening in the future. And sometimes that's what really matters, is preventing more episodes from happening in the future. Because the acute treatments are not so good. So this is a talk that I just went to, and I've basically gone over them already. So Depa Code, I'm not going to go into this in detail, but it's almost as good as lithium. So these are the mood stabilizers. There are a couple other mood stabilizers called the Modrogenic gabapentin. They're not really true mood stabilizers. Gabapentin in particular has not been shown to be helpful for people with bipolar. So I think it has some anti-anxiety effect. Lamotrigine helps a little bit with depression or the depressive phase, but it's still better not to get depressed in the first place. And we'll talk about that in a moment. Trileptal and Topamax, we don't know as much about them. Topamax, we know that it doesn't work, same as gabapentin, but some people do find it helpful. And Trileptal, we don't know whether it works or not. So it's kind of like a cousin to Tegretol. So we think maybe it helps, but we don't know as much. One editorial I want to say about how do we know if a medication is working. Part of the problem is when you take something like lithium, if you take it, you feel fine. You're like, what's going on? So you don't really know if they're working. You can only say that you're not being ill. So what happens is if you stop it and then you get ill again, then you would say, okay, maybe it was due to the lithium, but it could still be a coincidence. We never know, So, but over time, you can just kind of use your common sense. Okay, well, every time I've stopped the lithium, and it's been 3 times now, I have an episode. That should be enough. I mean, it depends. It's up to you to decide how many you need, but it is up to you. Okay, so that's it for the mood stabilizers. And again, it doesn't. So the antipsychotics we'll talk a little bit more about their side effects, and they have more problematic side effects, I believe, for most people. That makes them less ideal than taking like lithium. Okay, so let's talk a little bit. So hypnotics are these. Typically, they're called the benzodiazepines, and these are the common. Hypnotics means like. It doesn't mean like hypnotize, but in Greek, hypnosis means, ancient Greek, hypnosis means sleep, actually. So when doctors say they're hypnotics, that means these are just sleep medications. So many of you may have heard of Ambien or Zolpidem or Sonata. Those are sleep medications. Melatonin is a hypnotic. It just helps you sleep, for example. There are a bunch of benzodiazepines, like lorazepam, diazepam, and clonazepam. That's Ativan, Valium, and Klonopin. And they're all in the same kind of group, all the benzodiazepines, and the way they differ is some are short acting, some are intermediate acting, some are long acting. And now we don't use barbiturates anymore, like Seconal and stuff like that. And then there are some miscellaneous agents over here. So these are the sedative hypnotics. The advantage is that you get a rapid response when you take the sedatives, and I think overt abuse is rare, but what happens is people take more and more over time because you just get used to it. That's called tolerance. So one of the disadvantages was, well, there's a risk of OD, unless you're suicidal, it's not as high a risk. Side effects of sedation and grogginess, many people do feel that. There's the problem of tolerance. So after a week of taking these meds, you find that you'll need more to get the same effect. So over time, you kind of just get used to it. So in the end, it may not be that helpful, but it's good for the short term. Also, if you try to stop them, there's a withdrawal phenomenon and dependence. And then part of withdrawal is what we call rebound insomnia. Like when you stop it, you initially took it for insomnia. It worked initially for a while, and then it stopped working. And then you try to get off of it, then you'll have even worse insomnia. And so they're often not completely satisfying. And then the other thing is there's some evidence for dementia later in life, and hip fracture later in life. And a lot of studies just show that people who are on benzodiazepines don't seem to do that great over time. And that's just like associations. So there's a big push now for doctors to try to get people off benzodiazepines. So if your doctor's nagging you about getting off the benzodiazepine, that's part of what we've been taught more recently. Okay, so that was a set of hypnotics. Let me talk about the atypical. Any questions about the set of hypnotics? Okay, I'm going to keep moving on now. You have to remember, most set of hypnotics have not been tested for more than a week or 2. So so if you're on it for longer than that, and most people are, and I prescribe a lot of benzodiazepines to many people, and they do sometimes seem to help, but there is some concern with them. Okay, atypical antipsychotics. So someone asked me about antipsychotics versus atypical antipsychotics. So yes, the super group, the bigger group, is the antipsychotics, and underneath the antipsychotics there are 2 different kinds. They're the standard antipsychotics or traditional antipsychotics, and there are the atypical antipsychotics. And over time, atypical antipsychotics have become the predominant medication that people are taking. And there's a question of which category were sedative hypnotics in. Sedative hypnotics is their own category. So that's just so we have mood stabilizers, we have sedative hypnotics, and now we're going to talk about atypical antipsychotics. Atypical antipsychotics. Now, the thing that's different about atypical antipsychotics is that they are different from each other. So even though we cluster them in one group, they're actually pretty different from each other. Okay, so they each have their own, like, and this is what they call the Beachball model of antipsychotics. Each ball represents how strongly it binds to different neuroreceptors in your brain. So you can see how, if you just look at like these beach balls all look really different. And what that means is they have different effects on different receptors in your brain. So even though we categorize them in the same group, they're actually kind of pretty different. And each of the neuroreceptors, so there's dopamine, there's histamine, there's alpha-1, there's muscarinic receptors. Each one of those is kind of responsible for a different set of side effects. And so depending on how strongly it affects, you can kind of predict, it's not 100% by any means, but you can kind of predict the side effects of the antipsychotic. And so we do cluster the atypical antipsychotics in one group, but they are kind of different from each other, okay? Now here's a question about get easily sedated by medications. Risperidone and Latuda work best, but get tardive dyskinesia from them. Is there any medication that's less sedating like Risperidone and Latuda, but without a high incidence of TD? And unfortunately, I don't have any obvious answer to you. You have to keep working with your doctor to minimize side effects. Like which antipsychotic is best is like dependent on what you're treating it for. Risperidone, this is a study looking at the orange part is how acceptable was it to patients, and then the blue was how efficacious it was, okay? And so you can see a combination here of all these things like Haldol, Risperidol, olanzapine, and quetiapine had the best combination of both acceptability and efficacy. Okay, so that's. Now, if people are acutely manic, the combination of mood stabilizer and antipsychotic probably work best. Okay, so let me talk about tardive dyskinesia. Is this complicated? Someone had asked about like side effects in plain English. Tardive dyskinesia is one side effect. That's this neurological syndrome that includes abnormal movements of the hands and face. Okay, so if you want to look up more of the details of what that is, Wikipedia. Rates on those on atypical antipsychotics are about 20%, while those on typical antipsychotics range around 30%. And this is after several years or decades of usage. Okay, so basically, if you take it over a long period of time, you have this rate of tardive dyskinesia. And usually it starts as mild and it gets worse over time. So it's not as if you take a pill and all of a sudden you have tardive dyskinesia, which is abnormal movements of the hands and face. It takes time over time. And a lot of people actually do get a little bit better from the tardive dyskinesia. It's not 100% that it stays with you. And what happens is if you take the antipsychotic, it actually in a weird way kind of masks tardive dyskinesia also. So what people will notice if they're taking antipsychotics for a long period of time and then they stop it suddenly, they'll have like a little burst of tardive dyskinesia and then it will get a little bit better. Similarly, if one notices tardive dyskinesia, you can take more of the antipsychotic and that will like get rid of the tardive dyskinesia temporarily, but over time, like a few years later, it might come back again, and now you're on this higher dose of antipsychotic. The main thing is just to be aware of tardive dyskinesia, the early symptoms. Usually it takes like a year or more of being on this medication before you'll develop tardive dyskinesia. The other problematic thing is people do develop dyskinesias, which means abnormal movements that will have problems even without antipsychotics. So we do know that people who have, say, schizophrenia have a higher rate of dyskinesias than people who don't have schizophrenia. And we know this from the days before there were atypical antipsychotics. Now, clozapine, just to be more specific here, is thought to be the least likely antipsychotic to cause tardive dyskinesia. So If you go off the antipsychotics, you'll have this short-term increase in symptoms, but it gets a little bit better. Sometimes it goes away completely, sometimes it doesn't. And most antipsychotics have this long-term side effect. Some new medications have been developed, like valbenazine. If you want to see a manufacturer-sponsored website, check out, there's this link here. It's very expensive. Treatments for tardive dyskinesia, including this medication, are only modestly helpful. And like I said, they're pretty expensive. So obviously, it's better not to get tardive dyskinesia in the first place. And you can do that by minimizing your dosage of antipsychotic. So that's it in a very quick overview of the medications. Were there questions that people wanted to ask?
Someone wanted to know to go more involved in the receptors around some of the medications. I don't know if that's like too deep for what we're doing today.
I think that's probably too deep for what we're doing today. I would recommend you can go to look up some of the Wikipedia website about antipsychotics and stuff, and from there you can find more links to that.
And then someone wanted to know a little bit more about the side effects of Klonopin long term, like in, I guess, layman's terms. So dementia and hip problems were the ones that I got. And I can link to Wikipedia on dementia.
Yeah, dementia is. Do you need me to define dementia? Is that part of the issue?
I think perhaps.
So dementia is what happens to people over long term when they get older. A loss of brain function. So people have trouble with their memory and trouble with what we call executive function, like doing things. And sometimes it's called the most common kind of dementia is called Alzheimer's dementia. And so benzodiazepines have been associated with higher rates of dementia as you get older. So unfortunately, I think if we all live long enough, we'll all get dementia. Like apparently this is what epidemiologists tell me, that if we all could live to 150, we'd all eventually get dementia. So, but it does make it seem like benzodiazepines make it come on a little bit sooner. Hip fracture is also a common thing that happens when you're older that causes you to die. Basically, what happens is when you get older, you fall down, you break your hip, you go to the hospital, you get hip replacement. But while you get your big surgery, you get hip replacement, because it's such a stress on your system, you get pneumonia, then you get pneumonia, and then you die. So that's the typical course that we don't want to see happen to people, but it happens all too frequently. So one of the benzodiazepines impair people's balance. So like when you're young and you fall down a few times, that's fine, it's not a big deal. But when you get older, your bones get more brittle, you fall down, you break your hip, and then this whole cascade of events occur. So better not to break your hip.
Someone else.
Someone mentioned that they had tardive dyskinesia. Someone mentioned that they had tardive dyskinesia after one dose. That would be really rare. I think almost by definition, that probably is not tardive dyskinesia. That would be considered a dystonic reaction or other acute neurological symptom. But it sounds like if it stayed forever, then maybe it could be considered tardive dyskinesia. But tardive means like late occurring. So almost by definition, if you just took it once, it's not supposed to be tardive dyskinesia. But that's not, again, antipsychotics have these really other neurological symptoms that are bizarre and upsetting to people. What we call dystonic reactions, like people get like spasms of their neck and they get weird jerking and stuff like that. In general, those are thought to be benign, but they're very annoying. I don't want to minimize how annoying they can be and how upsetting they can be, but I would say that they don't mean that you're going to have that problem forever. But they can cause these, like people get slowed down. Sedation is another common side effect with atypical antipsychotics, and weight gain. So a lot of people don't like to take antipsychotics long term because you gain more and more weight the more you take them, and it's kind of a hard thing to lose weight once you gain it. So even though it's not theoretically irreversible weight gain, it is really hard to lose weight.
A lot of questions coming up. Maybe just one more. What do you know about the Invega injection? Okay,
now there are these. Sometimes they're called LAIs, or long-acting injectable agents. So Invega is I think long-term injectable of paliperidone or risperidone, one or the other. I don't know it off the top of my head here, but that's the brand name. And it is paliperidone and risperidone are very similar, by the way. And the nice thing about the injection, you don't just need one injection every 2 to 4 weeks. It depends on what kind it is. And you can just get that one injection. You don't have to remember to take a pill all the time. On the other hand, if you have a side effect from the medication, then you're stuck with it for 3 weeks while it's still in your system. So.
All right, and the others we can come back at the end if there's time.
Okay, we'll go back. Let me just keep going here. So a couple other slides I want to mention to you. So I think the way I think about it is when you're in the middle of a crisis, so there's two, like the way people, they're either in a crisis or they're recovering from a crisis or they're in recovery, right? Those are the, simplistically, you can think about our lives this way, right? And so when you're in a crisis, I think what happens is, or this is the way I think about it is, I care less about side effects, I care more about efficacy. I want the medicine to do what it's supposed to do. And then when the person's in recovery and they're doing well, then side effects are all that matter and efficacy matters a little bit less. Does that make sense? Because the person's not doing fine and you want to get out of their way so that they can do their life, you know? So if you're in a crisis, then we worry a little bit less about the side effects. So what I mean by that, like if people are about to get manic or they're really psychotic and hearing voices and feeling terrible and paranoid and stuff like that, then you might try like a Zyprexa, which is olanzapine, or Seroquel or Haldol, because that will help get rid of those symptoms right away, but they cause a lot of side effects in the terms of like sedation and stuff like that. Then as the person gets better, then I might think about like, okay, well, if particularly if they have bipolar disorder, for example, maybe a mood stabilizer would work better, but doesn't have as much side effects. So ideally, then the person's on like lithium or something like that. And with lithium, like I showed you before, you could try to minimize the amount of medicine until the person doesn't feel like they're taking anything and they just feel like a normal person. That's the ideal. And it's hard to feel like a normal person sometimes if you take like 20 milligrams of Zyprexa every day. It's just like you're not feeling normal. It's just like that's a lot of medicine. So for some people can tolerate that. And so what happens is when it's a crisis, it's emergency, you just go gangbusters on the medicine to get out of that. Whereas when you're feeling good, then what happens is to prevent yourself from going to crisis, that's where being on like the right medicine that doesn't bother you too much, and then your own skills about not getting into trouble that not to do things that will cause a crisis, like drink a lot or use a lot of drugs or stay up all night or whatever it is. People have their own different vulnerabilities. So there were a lot of questions about going off medications, and so I just want to mention that psychotropic medications may be clearly indicated in many cases for treatment for mental illness. I'll just say as a blanket statement, and then let me talk about like how to taper off your medications. And here's a little link of how to taper off your antidepressant, but the same principles hold. It's like, it's best not to go off things cold turkey. If at all possible, if you have to go off a medication, go off gradually. And I would recommend that you tell your doctor about you want to go off medications. That a good doctor is used to that kind of question, So, the way I think of it is like, you don't have to take medications that I prescribe you. This is not an inpatient unit. You haven't got, like when people are in a crisis and they've lost like kind of their judgment and they're dangerous to themselves or other people, then they're in a psychiatric hospital. Then a judge can come by and make people to take their medication. But in the typical situation that I work in, like no one has to take their medicine. All I have is moral persuasion that I have. And usually what I say is, tell me if you want to go off your medications, and we'll work with you about that. And basically what we do is we try to decrease the medications until if there's a problem, then we can go back on the medication. So if you go off cold turkey and then there's a huge crisis, so you get in the hospital again, that sucks. It's much better if you go down slowly, have a little bit of symptoms and like, oh, hey, I can't do that, and then need to go back on it, or go off medications entirely. That's okay too. But just to think about that in a realistic way. I mean, doctors, I don't know. One of the things we don't like is when our patients get really sick and go to the hospital. We just don't like that. Altruistic and selfish reasons. It's a pain for everyone involved, more for the patient than for me. But I don't like it when my patients get sick and have to go to the hospital. So we definitely have a tendency to be more cautious, and that's kind of our job, maybe. So don't feel bad if your psychiatrist gets anxious and gets worried that you might get ill again. But I do think it's our job to help you find your way in life, and it's not necessarily a bad thing that you want to get off your medication. That's normal. I'll just, the moment of truth is when the person says to me, Dr. Lee, I want to go off my medications. Or more often it's like, do I really need to be on medications? Like, why am I on these things? I had this episode like 2 years ago and I feel fine now. Do I really need to be on medication? And I used to be kind of bummed and, like I mentioned, to get anxious about it. But now I kind of feel like, oh, that means I've done my job correctly, right? You feel like you're a normal, my job is to let you live your life, I feel like. So you feel like a good normal person and you don't need medications. That means I've done my job. I think what I would say though is, so I feel like I've done my job. And sometimes what I do nowadays is, people are doing really well, and after a few months they're like, oh, I'm never going off my meds. I'll say, yeah, you say that now, but a few years from now you're going to say, why, Dr. Lee, why am I on this meds? I've been taking this medicine faithfully every day for like 2-3 years, and why? I don't even know why. And I'll just say, I'll just remind you, okay, you've taken it, and remember what I told you last time, and this is the discussion we had. But I would say that it's normal to go off your medicines, or at least try to. And so sometimes people feel really guilty about going off the medications and then getting ill again. I don't agree. I don't know. I don't want to make you feel guilty about feeling guilty, but I think it's totally normal. I know if it were me, I would probably need to get hospitalized at least 3 times. I think a normal person maybe probably at least 2, but I'm a stubborn person. So I would probably need to become psychotic and hospitalized at least 3 times to convince me that I need to be on these kinds of medications long term. So I just think that's normal. So what my little tips would be, check what the doctor is prescribing your medications. If you're going off your medications, tell them that you're going to do this. Tell your family members that you're going to go do this also. And then make sure you try to think in advance about, like, what are the symptoms of withdrawal of the medication versus recurrence of the illness. And then make an early action plan for if the illness recurs. So if you start, so what that means is you have to go and think back, like, what were the early symptoms of my illness? You know, sometimes people start spending more money, some people sleep less. What were the early symptoms, and what am I going to do if I start having those early symptoms? And to plan for that in advance, and plan for that with your family or loved ones, that you're all going to agree that, because what happens is sometimes when people become manic, they lose kind of they become really self-confident, and part of that means they feel like they don't need to be on meds. And so they have to, you know, there's a point where it's too far gone, you can't convince the person. But early on, I can't tell you, once you get the hang of this, you can tell that you need to be on medications early on. And if everyone agrees, and sometimes you need feedback from other people in your life who you trust, and that might be your doctor, that might be your family member, and to go back on the medication. And then the other tip I mentioned was to decrease gradually over several months, ideally, and then to use a chart or diary to track dosages and symptoms if you have any. You know, so when you write down the day you're decreasing the medication, write down each date that you decrease it a little bit further, because, you know, this is like a natural experiment that you're doing, and you want to make a record of it, because, you know, you're taking a risk here, or you and your doctor are taking a risk here, and even if something bad happens, you want to at least have learned something from it. I think that's the most important thing, that every time something happens is you can learn from it, you know. Now, I would also say that when you get these early symptoms, you also should think a little bit about a threshold, meaning, like, sometimes people have a symptom and say, okay, if this means that I'm only a 1% chance, that means I'm going to get ill, I still don't want to take medications. But if it's a 90% chance that this means you're going to become ill, more seriously ill, would you take a medication then? So think about, like, at what point in the probability will you want to take a medication? Some people are like, I never want to get hospitalized again. That was the worst thing that ever happened to me. If there's a 10% chance that that could happen again, I want to go back on the medication. So what happens is sometimes people could get early symptoms and write them out. And if you can write them out 9 out of 10 times, that means you got a 90% chance. But even that 10% chance of kind of losing it, as it were, and getting hospitalized may not be worth it to you. It depends on each individual person. So some people are like, if it's a 50-50 chance, I still want to take a chance of going off the medicines. But it's up, you know, it really isn't. I encourage you to think about it in advance. Okay, so question: family member takes lithium 400 milligrams a day. Lithium comes in 300, so that dosage doesn't seem quite right. Maybe it's 450. It comes in 300s and 450s and 150s. Now, this is the hypothyroidism thing. Most doctors find treating hypothyroidism far easier than treating bipolar disorder. We can replace what the thyroid gland makes with pills relatively easy. We don't have the same effectiveness with mental illness. So many doctors will just say hypothyroidism, that's nothing. Tons of people have hypothyroidism. We can just replace your thyroid, not a big deal. And the body also, even though your thyroid gland, which is in your neck, is missing or gets suppressed, your body has other like enzymes that modulate thyroid metabolism in your blood, basically. So if the exact amount in the pill isn't right, your body has a way of like making it closer to the correct amount. So your body, we actually don't need our thyroid glands in modern day because we can take pills. Long-term side effects of lithium. Yes, you have to, I recommend seeing some of the prior slides. Also recommend talking with your family member's doctor or pharmacist and or checking WebMD. This is the website for WebMD. And then I mentioned clozapine. I'll talk a little bit more. I think I mentioned clozapine already. Okay. So bipolar disorder the treatment is phase dependent. So if you're acutely manic or having a mixed episode, which having depression and mania at the same time, which is pretty terrible, I think, you want to take mood stabilizers plus atypical antipsychotics and benzodiazepines, maybe, because that can help with, that just a little bit of that can be helpful too. But remember to stop antidepressants. For people with bipolar disorder, antidepressants in about 10 to 20%, we're not really sure, it depends on the person, it can trigger these manias and mixed episodes. So, and rapid cycling. So just remember that if you start that antidepressants are generally, kind of not good for people with bipolar disorder. But what if I'm depressed, Dr. Li? Well, if you have bipolar, it's really difficult to treat bipolar depression. And there's some subset of people who have manias and then depression. So like they have manias and they're followed by crashes. In those individuals, if that's the pattern that you have, you can actually eliminate the depressions by preventing the mania, right? So the mania is what you want to get rid of. We can actually prevent manias. We have a tougher time. Once you get manic, it's almost inevitable that you'll have a depression. For people who are prone to that, it's just like, I find it really hard to get rid of the depression after that. And then for maintenance, once you're better and you've got you're not depressed and whatever, what you want to do is you want to taper off the atypical antipsychotics and the benzodiazepines and just stay on the mood stabilizer if you can. Some people need to be on a combination of both, but work with your doctor about that. And then this is the time to take a class. We have a bipolar class, by the way, about bipolar disorder at UCSF. And it's good to take a class you can learn about. I mean, I'm going through this really fast. We'll go faster. So what is psychoeducation? It's a course in which patients will learn what bipolar disorder is, techniques and tips to better manage the disorder. We now do it all by Zoom, but we used to do them in a little classroom like this. This is not real patients, it's something I got from the internet. The formal psychoeducation is 21 group sessions of 90 minutes each. We have 8 sessions. We have 2 series. One starts in September. Well, now it's in June. Actually, we have another one starting at the end of June, another one in January. This is kind of the content. So we talk about sleep, we talk about the meds, mood charting, and there's a lot of like talking with each other and sharing tips and techniques and stuff. It's not like your classic psychotherapy course, group psychotherapy where you're talking about how much you don't like the other person or how they make you anxious or whatever. Nothing like that. This is more about mutual support and helping each other, getting through the tough times and sharing our experiences. Okay, so this is time for the Q&A, and these are some of the Q&A that I got lined up here. Someone asked me about novel mechanisms of action by major pharmaceutical or biotech companies, new meds basically, developing companion biomarkers or diagnosis. This is a super exciting area. I don't know much about it. I'm kind of an old-fashioned psychiatrist. I just treat people with what I know. There are some new, also pharmaceuticals have built any drugs that address cognitive function like memory or ability to focus. I would say not really. We have psychostimulants like caffeine or Ritalin or Adderall that can be helpful but are of modest efficacy. They don't like get people to the next level oftentimes, like they can make you feel more awake and stuff, but we don't know much about the long-term usage of psychostimulants. My personal feeling is the brain is pretty complicated and it's hard to improve on how it works. Because if you think about the brain, it's millions of these or billions of these neurons. Taking a pill can't make it work that much better. It's like if you have a cell phone and you wanted to make it work better or faster, there isn't like one thing you would do to just enhance it. You would try to like tweak it, and there are better apps and stuff, but you can't like improve on it in globally.
Some things that I've listed from the chat box. People wanted to know about ADHD, bipolar comorbidity. I'm having a hard time. How common is it? And if the ADHD diagnosis is a sure thing, isn't it more likely that the comorbidity would be bipolar depression?
No, people have, ADHD and bipolar disorder are comorbid. And what that means is they happen at the same time. Now, people will have bipolar disorder, have ups and downs, and on top of that, will have ADHD. We used to not think that people had adult attention deficit disorder, meaning you had the classic attention deficit disorder, or how to start as a child, and it basically doesn't get any better. And so there is a belief that people do have adult onset attention deficit disorder, but usually if someone has new onset attention problems, that's often better explained if people have anxiety all of a sudden, then that can cause problems with attention. If you have schizophrenia or bipolar disorder, that can cause problems with attention. So we try to treat those other things first, and then we'll try to treat the ADHD. Because if we think of attention problems as part of another disorder, that's more likely. So.
To clarify, it's more unlikely to have unipolar depression with ADHD. So if you have depression and you have ADHD, I guess this person is asking, it's more likely to have unipolar depression?
If you already have ADHD, is it more likely to have bipolar disorder or unipolar disorder? Is that the question? I don't know the answer to that. I think unipolar depression is probably more common just because it's more common. But bipolar disorder and ADHD, for people with bipolar disorder, compared with people without bipolar disorder, people with bipolar disorder have a much higher rate of ADHD than people who don't have bipolar disorder. So if you compare a group of people with bipolar disorder, a group of people without bipolar disorder, a person with bipolar disorder has a higher rate of having ADHD.
Someone else asked about, I think people are interested
just one more thing. So psychostimulants in bipolar disorder are very risky too, because they can trigger mood, they can trigger cycling and mania as well. So psychiatrists are very reluctant to prescribe psychostimulants to someone who has bipolar disorder. So it's probably first to get treated, and the general rule of thumb is treat the bipolar disorder, make sure the person isn't manic or depressed, that's causing the problems with attention. And then if they're like feeling fine and still have an attentional problem, then you will very carefully try psychostimulants. Yeah.
Makes sense.
Is there a cure? Is there a cure or lifelong control of bipolar disorder with psychiatric medication? Some people do much better with psychiatric medications, others do not. You know, it's like we have a cure for some cancers, but we don't have a cure for all of them, unfortunately. What is the damage that can be caused by the liver, to the liver? That depends on the medication. Most medications don't commonly cause liver disease. If they did, they would not be FDA approved. Some things occasionally cause liver problems, like Depa Code, in which case you have to get like liver tests like once a year or something like that. People ask, should I take medicine for the rest of my life? They have to talk, that's an individual thing, you have to talk with your doctor. What is the effect of the drug on a neurological level? Well, we don't know how the brain works exactly, so we don't know exactly how medications work. There are theories about how medications work, but it depends on the medication and the disease. So you can ask your psychiatrist about, like, how does this drug work on a neurological level, but don't expect a wonderful answer. We don't really know. If you want to find out from the internet, you can Google your medication, the name of your medication, and then say mechanism of action. And that will give you some explanation of how medications work, but not easy to answer that question. So there's a bunch of questions about if your loved one has gone off medications and doesn't want help. There's this excellent book called I Am Not Sick, I Don't Need Help by Javier Amador. I just looked it up on Amazon earlier today. It's $22. I highly recommend it. How to help someone accept treatment. It's very well written and very commonsensical. There's this little article written by Julie Fast for bipolarhope.com, which is like a magazine for people with bipolar disorder. So it gives you little tips about how to talk to someone for getting help with unmanaged bipolar disorder. NAMI is a great resource, and this is the links to their websites. There's another book, Surviving Schizophrenia, which I really like. These are resources for bipolar disorder, and these are some other books that I all like for bipolar disorder. So that's the end of the slideshow. And maybe I'll stop sharing for now and just take a couple more questions. We have 7 more minutes. And in the meantime, I'll put my slide in my in a Dropbox link and people can access it that way. Or should I just send it to you? And it'd be good to put it out on the link now, right?
Slides way too fast. Can we get a copy? Yeah, people definitely want a copy. That was asked earlier. I think that it might be easier if you send it to me. Dropbox can be kind of complicated for people that haven't used it. And then I think what I'm gathering from some of the questions, people wanted to sort of know more about strategies for schizophrenia to deal with voices, and any medications developed to treat the cognitive side effects of schizophrenia, such as memory or attention deficit, which I think you touched on in a place or two.
Yeah, so let's do one question at a time. So the first one is, what was the first one again? I forgot the question.
Strategies to deal with voices or auditory hallucinations with schizophrenia.
Oh, okay. There are some, again, I would look up the NAMI website and I would look up the NAMI website and find the, and there's probably some resources there about how specifically how to deal with auditory hallucinations. You know, one thing is like, it depends on the content of the auditory hallucinations. If it doesn't bother the person that much, I try not to, I don't worry too much about auditory hallucinations if they don't bother the person. Sometimes they can be very nasty though and kind of have this negative commentary all the time, which is kind of a pain. Then in that situation, I will, obviously it's better to try to get rid of it. But I'm in the mode of like, sometimes they're supportive. So I don't care that much. Okay, I sent you the link, Simone, of a PDF of the slides. So hopefully people the links will be.
I'll send that out with the video. We've just got 5 more minutes, and I put the NAMI link about schizophrenia in the chat box. I thought I would take one more question. People wanted to know if does Buspar, this is an old one, but does Buspar have withdrawals like benzodiazepines?
Does what have?
Buspar?
Not that I know of, or it's not very strong, but I still, unless you really have to, just taper off slowly. Benzodiazepines probably have the strongest withdrawal, but it turns out antidepressants and antipsychotics have withdrawal syndromes also. We do know from earlier research that lithium, if you stop it cold turkey, you're at a greater risk of having a bipolar relapse than if you stop it gradually. And by gradually, that means more than a month. Because what they did was when they were first starting to study bipolar medications besides lithium, they would take a new medication, then they take the person who's already on lithium and switch them to the other medication. But it turned out that if you just inherent in switching the person, just taking them off the lithium, if you did it too quickly, that would trigger a relapse already. So it's better to taper that off slowly if you can.
And I think this is our last one, and then we're going to have to close it down for today. But could you comment on Lamictal? Isn't that preferable because there's not as much weight gain?
Yeah, Lamictal is an excellent medication. It's easy to tolerate. The couple of problems with it, though, is one is that you have to taper it over a long period of time, like build up the dosage. So it takes like 2 months to get up to the target dosage in terms of its strength, because it has this. If you take it too quickly, you get this allergic reaction called Stevens-Johnson syndrome, which is can be life-threatening. So you have to gradually taper it up. The other downside with Lamictal is it doesn't really prevent manias. So if you're in that group of people who have manias, then depressions, it doesn't help with that cycle so much. So if you want to get out of that cycle, something like lithium will prevent you from, not always, but for many people will prevent you from having another episode. And so then going forward, you'll be in better shape. You know?
And I guess there's one more that I think we can sneak in. Are there any, this is very specific, so this might be more of a Google search question, but are there any 10 to 30 year generalized longitudinal side effects of Abilify around ages 40 to 60 in men and women? Very,
when they don't, it's really hard to follow these medications for long term. So I'm just going to answer this kind of generically with why it's hard to give you an answer. And then the answer to that question, why it's hard to give you an answer, is because they follow people over long periods of time, but up to a long period of time in most studies is like 8 weeks. And then a study that gets to fund a study for 8 weeks of like, you need to have like 200 to 600 people in a study. To fund that study, it costs already like millions of bucks, right? So the drug company is not motivated to fund really long-term studies. Well, we do have like these like kind of what they're called surveillance programs. Like every time you have a side effect, then you call in and say, I have the side effect, or the psychiatrist calls and says, and so that's only like a post hoc analysis. We don't really know, like, is it because the person has bipolar disorder they're more likely to have this, or because they took this medication compared with others? So it's really hard to say sometimes. So,
and I guess the final thing that
yeah, so the long-term side effects of medications. Yeah.
Quickly comment on, if people have more questions that like, where's the best resource that you would send them to get questions aside from, I guess, their doctor, their questions answered? Doctor,
pharmacist, NAMI is a great place to get. WebMD is a really reliable resource. NAMI is a reliable resource. DBSA website's fantastic. Those are all like reliable websites. There's a lot of weird stuff out there sometimes, and you'll get, but those are pretty conservative, and so when they say stuff, it's pretty, you know, they're not going to go out on a limb and say something kind of dramatic. All right. So this has been great. Thank you guys so much. These are great questions. I mean, I think it's been fun to do this with you guys, and you know, we can try again some other time if there are more questions. If people feel like this was worthwhile. Yeah, thanks so much, Dr. Li, and thank you everybody for coming. This has been so rewarding. And yeah, I'll make sure to share that video as tomorrow morning. So have a great evening, everybody. One big final shout out. Let's everyone thank Simone for organizing.